Hello, everyone. Good afternoon. On behalf of the BC Health Coalition Steering Committee, I'd like to welcome everyone to today's provincial campaign call for funding reform in the long-term care sector. My name is Margot Beauchamp. My pronouns are she, her. I represent the Jewish Seniors Alliance of Greater Vancouver at the BC Health Coalition, and I will be one of your co-chairs for today's event. Before we begin, I'd like to invite you to join me in a land acknowledgement. Please use the chat to introduce yourself and share the name of the territory or land from where you are connecting from. The BC Health Coalition acknowledges we are based on the unceded and traditional territories of the Coast Salish nations of Musqueam, Tsleil-Waututh, and Squamish. We also acknowledge the many territories and lands across Turtle Island that you are joining us from. We are honored to be here as guests on this land that Indigenous peoples have cared for and continue to care for. We invite you to take a moment to think about where you presently live and honor the people of the land. Think about your relation to the place you live, work, and interact. This is our inquiry to honor the past and present and to stay connected to the decolonization practices. We invite you to use the chat to share the name of the territory or land from where you are connecting from as part of this acknowledgement. Thank you.
Good afternoon, everybody. My name is Scott DeLong, and I am the Vice President for Community Health with the BC General Employees Union. And I represent the BCGU at the BC Health Coalition, and I will be your other co-chair for today's event. And at the BC Health Coalition, our role is to bring together a broad cross-section of civil society to fight for public solutions to healthcare issues. Our organization is a democratic, inclusive, and a consensus-based community of individuals and organizations dedicated to advocating for evidence-based solutions, defending our public healthcare system from for-profit interest, and building a constituency to support and demand change where BC residents need it most. For today, we are coming together as individuals and organizations to express our concern about the extraction of profit in the publicly funded, contracted long-term care system. We're here to send a strong message to our provincial government. We support fundamental funding reform that will improve transparency, accountability, and ensure public money directed at care is spent on care, not profit. We're delighted to be joined by this BC Seniors Advocate, Isobel Mackenzie, who will speak about her office's latest review of the contracted long-term care sector and share her office's recommendations for funding reform. We'll have a short question and answer following Isobel's presentation, encouraging you to use the chat to share your questions at this time. Following our time with the Seniors Advocate, we'll hear from some coalition members who will be sharing updates on the progress that have been made in recent years on long-term care reform. We have a long way to go yet, but it's important to take time to share our wins, give recognition to our government for their commitment to reforming long-term care for the better, and learn from our successes. Before we wrap up, we'll be asking each one of you to take action to support the bold funding reform we need. We are launching a new postcard campaign and need everybody to help us out. We need many people as possible to send postcards in support of the funding reform. Stay tuned for the details later in this call.
Thanks, Scott. Before we get into it, we wanted to take a moment to review the context of long-term care and remember the work we've done together to support improvements in our long-term care system. We know that decades of privatization, even before the pandemic, had left our long-term care fragile, but COVID-19 really exposed the weaknesses of the system and brought forward a wave of public demands for action. The BC NDP government was quick to demonstrate a willingness to take bold action and make significant investments. They made strong commitments to seniors' care in their previous election platform and reiterated these in the Minister of Health, Adrian Dix's mandate. Last year, the BC Health Coalition and organizational partners representing thousands of seniors, their families, and workers held an accountability assembly where Minister Dix was invited to present on the significant reforms the BC government had promised and delivered. Many of you or your organization were represented at that assembly. At that time, Minister Dix shared that his ministry was working on a standardized funding model for all long-term care operators that would ensure greater transparency and accountability for how tax dollars are spent. We're here today to follow up on that commitment. Last month, Seniors Advocate Isobel Mackenzie released the report, Billions More Reasons to Care. The report reviewed the financial reporting of the contracted long-term care sector and found that for-profit operators more than doubled their profits in 5 years, all the while under-delivering almost 500,000 hours of direct care that had been funded to provide. These findings add urgency to the need for funding reform, and we know it's going to take a strong show of public support to bring about the reforms we need. That's where all of us come in. We're going to hand things over to the Seniors Advocate very shortly, but first I'd like to invite Audrey to lead us in a quick poll activity. Thank you.
Thank you, Margot. Hi, everyone. I'm Audrey Gay, organizing with the BC Health Coalition. My pronouns are she, her. Good to see so many of you here in real time on the call. I think we've got 176 participants here so far. Numbers keep going up, so that's really good. Thank you for being here. Many of you will know that as a team, we sent out a short survey a couple of weeks ago to get your input and our membership's input about priorities for funding reform in long-term care. And so we wanted to do two things. First, we're going to try out a Zoom poll, which is just a way to get your input here in real time. So hopefully that's a nice way to get your engagement. And we're going to try it out, knowing that technology is not always on our side. So thank you. My colleague Usman has just launched that poll. And so it should bring up two questions on your screen. And we'll give you a moment to look over it and give us your answers. The first question is, what's your connection to long-term care? Do you live in long-term care? Do you have a loved one who lives in long-term care? Do you work in long-term care? Or do you have some other kind of connection, which could include maybe one day I will live in long-term care, or I will have a loved one in long-term care. So we all have a connection to this issue in one way or another. And the second question has to do with your priority for the new funding model. So we've got a few wordy answers there for you to choose from. So I'll maybe give you a chance to look them over. But the gist of it is, requiring that funding be spent on care and not go to profit, wanting to improve accuracy and transparency of reporting, ensuring common employment conditions across the sector by standardizing wages, benefits, and working conditions, and then taking into account input from key players or partners in long-term care sector when developing this new funding reform. So maybe I'll check in with my colleague. How are we doing in terms of responses, Usman? Should we leave it open a minute more?
We should leave it open. We have about 15% who've responded so far. So if you haven't responded, please do. It should be up on your screen.
Okay, and also don't concern yourself too much if the technology is not working for you. This is more of an experiment. To take it as a fun experiment rather than being frustrated about tech issues, because we know those happen. And I'll just leave that open a bit longer. I guess the poll has ended, so you should be able to see the results on your screen. We see that the majority of us on the call, 69%, have an other connection to long-term care. About a quarter of us have a loved one who lives in long-term care at present. And we've got almost 10% of people who work in long-term care. And I think that is pretty close to what we saw in the survey that we sent out in terms of spread of respondents, but I'll share that in a minute. And then the other question, so it's a hard question, I know, because I think if you're like me, you want to see all of these things happen. So it's not a fair position to put you in choosing one. But 60% prioritize requiring that funding for care be spent on care. So let's and you can close out of that. And what I'm going to do is share my screen and share some of the other results that we got from the survey that I expect many of you completed. Can everyone see the pie graph on the screen? Can I get a thumbs up if your video is on? If you can see that. So as I said, a pretty close spread, similar to what we had today in terms of who responded, the majority having an other connection to long-term care. We did get 1%, and I should say we had about 1,600 respondents in just under a week to this survey. So pretty good responses. We were really happy to see that. And about 1% of those lived in long-term care. So we were excited to see that we were able to reach residents as well. So this is another interesting one, just in terms of spread of priorities. Same as we just saw, a majority will prioritize when forced to funding being spent on care, but also some strong support on the other priorities. And this, I apologize for the small graph, but this question released people from having to make that what's my number one priority and ranked the different suggestions for improving the funding model that we had. So they're the same that you had in your question. And what I want everyone to take away from this slide is that the vast majority of people either strongly supported or somewhat supported all of the suggestions for funding reform. And so we know that there's really, really strong support for all of these initiatives. And so that will be really helpful in our advocacy to the provincial government and being able to say the public supports you. You want to bring funding reform, like people are behind you. So let's make it happen. So I think that'll be it for me. Thanks everyone for participating. I am handing it back to Scott, who's introducing our guest speaker.
Thanks, Audrey. It's my distinct pleasure to introduce BC Seniors Advocate Isobel Mackenzie. Isobel has over 20 years' experience with working with seniors in home care, licensed care, community services, and volunteer services. Isobel led the BC's largest nonprofit agency serving over 6,000 seniors annually. In this work, she led the implementation of a new model of dementia care that has become a national best practice, and led the first safety accreditation for home care workers, among many other accomplishments. Isobel has been widely recognized for her work and was named BC CEO of the Year for the nonprofit sector and nominated as a provincial healthcare hero. BC is the first province to have created the Office of the Seniors Advocate, and actually the Health Coalition was a key player, along with our partners in the CCPA BC, in establishing this role. Since the Seniors Advocate mandate was established in 2013, we have benefited from the high-quality monitoring and analysis of our senior services. This evidence helps us know where the systemic issues are in our system and what can be done to protect, what can be done to impact them. As a Seniors Advocate, Isobel has led the important work which this province and its seniors greatly benefit from. Thank you.
All right. So thank you very much for the opportunity to talk to you about the findings of the latest report from my office. It's called Billions More Reasons to Care. It's a follow-up to a report that we issued. The report was issued about 3.5 years ago, but the data was from 5 years ago. And that report was called A Billion Reasons to Care. And it looked at basically, the premise was we need to look at the contracted care sector in British Columbia and understand where money is being spent, how money is being spent. And the reason why we should be paying attention is because it is over $1 billion a year, close to 2 billion now, that transfers from the public, from the government, over to the private sector. And about a little more than half of that is private companies, and a little less than half is nonprofit societies. But it is a transfer of public money to the private sector, so we should be paying attention to it. And we found some issues of concern and made some recommendations in that report. And so 5 years later, in terms of, what did things look like 5 years ago in the data, what do they look like today, we thought it was timely to do an update. And the previous report is on our website as well. So just to frame it, as I'm sure you all know, what's been happening in the last 5 years, about 6 or 7 weeks after the first report came out, we shut down our long-term care system. We had our COVID-19 pandemic. We've had some good things happening. Some of those good things have happened because in response to bad things happening, like the pandemic. But there's been significant increases over the last 5 years to both our funding to long-term care. That funding has translated into funding for hours of care. The funding for that has increased dramatically over the last 5 years. During COVID, we saw the wage leveling. That was part of the single site order. That was something that we felt was integral to bringing greater parity amongst our care homes. And one of the recommendations from our last report actually has been implemented. It's the development of a standardized provincial reporting template. I would describe it as still in its infancy. It's not yet being used to make funding decisions, and it's getting the kinks ironed out and all of that. But the important thing is that they have actually come up with one, and they have recognized the need to have the standardized provincial reporting to get that information. The other thing that has happened, mostly in response to COVID and also badly needed even prior to COVID, is a training program for care staff in long-term care. It's called the Healthcare Career Access Program, or HCAP. It's been very successful. The commitment is to continue it. I think that's good news. And it's training the care aides, the housekeeping staff, the food services staff in long-term care, where I think we, with the significant investments we've made, we've increased the pool, if you will, the labor pool quite a bit. Bit trickier for nurses, obviously, and doctors. That's a longer training time horizon. But certainly when we look at the care staff who have the most interaction with our residents, we've seen a significant increase in the pool. We've grown the labor pool, if you will, which makes some of our findings interesting as well. So the year that we looked at was 2021-2022. So towards the end of 22, life was returning to normal for the most part in long-term care. It was the end of our second year of COVID. We were also able to then capture a 5-year comparison, 3 years prior to COVID, 2 years of COVID, not included in the report, but we were also able to look at most of the 2022-2023 data to see that, there wasn't this dramatic change in 2022-2023 that we were going to see. So that's why we picked that year. We like to have a year where we have complete data, and just the timelines involved in terms of the length of time to analyze the financial reports, et cetera. We need a little bit of runway there. So in 21-2022, there was $3 billion spent on long-term care in total. So whether it was owned and operated, contracted, it was basically $2.9 billion in long-term care. That's a 45% increase over 5 years. And what's important to understand is during that 5 years, inflation was 15%. Remember, we've only just started to see these high inflation years in the current fiscal year that we're in, and in the fiscal year that just ended. So in 2021-22, inflation was not high, and in the preceding years, it was quite low. So we had low inflation, and we haven't grown the number of beds dramatically. I think it was 1% or something. So we are spending a lot more money effectively for the same thing today than we were 5 years ago. So that's important to recognize. Of that $3 billion, $2 million of it, most of it, is spent in the contracted sector, 65% of all spending. And the amount spent in the contracted sector went up by 35%. So less than owned and operated. There's a number of reasons for that. But still well in excess of what you would call inflationary costs, and certainly well in excess of capacity increases costs. So it's important to recognize that while operators talk about their rising costs, their funding has risen to meet those costs. And then some, if you take inflation as the biggest indicator, again, 15% inflation, 35% increase in funding. So while there's been an overall 35% increase in funding, every category has not increased by that specific amount. And so we've created 5 buckets, if you will, for spending. We did that in our last report, so we did it for this report so we can compare. Bucket number 1, the largest bucket, is direct care costs. It's where most of the money goes. It's where most of the people are, because it really is mostly what long-term care is about. So over the last 5 years, there's been a 33% increase in direct care costs, and that's reflective of more staff and also reflective of the wage leveling. So funding more for staff. Same increase in non-direct care staff. So non-direct care staff are food services, laundry, housekeeping, administration, management. It's basically everybody else that gets a paycheck who isn't in direct care. And I should qualify, direct care means nurses who are, what in my day we used to say on the ward, the nurses who are at the front line of providing the care. So if you're a nurse administrator, you're not providing direct care. It includes the allied health, so physical therapy, occupational therapy, and of course it includes care aides, which is again the bulk. Care aides are just about over 70% of direct care costs. So capital building costs increased by 18% over the last 5 years. So those are mortgage costs, depreciation, capital maintenance, those kinds of things increased 18%. There was a 61% increase. It's the second largest increase percentage-wise in supplies, administration, and other. Most of this reflects what we did in our infection control in response to COVID. And you can see that because you see the big spike in the 2020-2021 year, the first year of COVID. So this is where everybody's gloves and gowns and masks and hand sanitizers and all of that kind of thing is captured, is in this bucket. So that's why that went up so high. But the largest percentage increase, although the smallest in terms of money, was profit, which went up 113% over the last 5 years. It and you'll see when we get to it, it's not uniform in terms of across each site. So that's also important to remember. So as we did in the last report, we looked at what are the differences between for-profit and not-for-profit, if any, and we continued to see the same differences that we saw 5 years ago. So we continue to see that the not-for-profits are spending a higher proportion of their funding on direct care and non-direct care. So basically the people, they are spending less on the buildings, on the mortgages, on the capital asset, and significantly less profit and surplus is accruing to not-for-profit providers than for-profit providers, notwithstanding a similarity in terms of funding. So direct care staffing expenditure per bed, and this basically shows you every year. So some people want to, distract the conversation by talking about, oh, it's the COVID year, and oh, everything was chaotic, and we should focus on how we all worked together. And all of those things are true. But what you can see is whether it was pre-COVID or during COVID, or sort of even in the getting into the post-COVID year, you see that the not-for-profits consistently spending more per bed. So per bed is the most equitable measure, because it doesn't take into account, smaller the bigger, what it's per bed or per resident. You can see that they have consistently spent more per bed than the for-profit facilities, notwithstanding a similarity in funding and in funded hours. So overall, what did we find? Well, 5 years ago, there was an under-delivering of care hours by the for-profit sector to the tune of about 207,000. The not-for-profit sector over-delivered by 80,000 hours. Fast forward 5 years later, the not-for-profit or the for-profit sector under-delivered by 500,000 hours. Actually, I think it's technically 530,000, but we rounded it down to 500,000. And the not-for-profit sector over-delivered 93,000 hours. Now, the important thing to remember is that the conditions of the sector are the same for all operators. Whether you are for-profit or not-for-profit, all of the conditions around COVID, staffing shortages, they're exactly the same for-profit operators as they are for not-for-profit operators. And yet consistently, there is this pattern. And so you have to ask yourself, why? And the answer is that all things being equal, for-profit operators behave differently than not-for-profit operators. That's not a judgment. That is a statement based on all things being equal. Why are we seeing these? What is the variable here that's different? And I think it also intuitively is what we would believe. The challenge is that the funding formula doesn't acknowledge these differences. And so, when Scott was talking about the goal of the coalition around changing the funding formula, that's, I think, what we need to focus on. Is the funding formula needs to reflect the realities of how, for want of a better term, if you were an economist, you would call it how the markets are behaving, the market of not-for-profit and the market of for-profit. Building expenses is another area. And we found in last year, similar to 5 years ago, for-profits spending much more per bed on their buildings than the not-for-profits. And this is an important thing we need to remember. When you comb through these hundreds of, I guess there's 200, financial statements provided by the operators, they're expensing their building. So we're paying the mortgages. Sometimes we're paying both principal and interest. Sometimes we're paying interest only and allowing depreciation. But at the end of the day, we are paying for this building that we do not own. And so when the operator is putting forward the expenses they need to have covered, the not-for-profits are not getting the benefit of that to the same degree that the for-profits are. And it's an asset that is owned by the operator, not by the funder, even though the funder has paid for it. Now, the operator is entitled to be compensated for the use of the building, whether they're a for-profit or a not-for-profit. The most equitable approach would be to not look at whether there's a mortgage, how much the mortgage is, but to come up with a formula based on age of building, square footage, etc., and to say we're going to fund X amount per square foot of building in this building category, and be agnostic to whether they're for-profit, not-for-profit, have a more, because the ability and agility that some for-profit operators have within this category to shift monies about is significant. And so we've got to be careful around making sure that we're compensating an operator for the market value of the use of their building. Profit. So it's an interesting thing. A lot of people focused, I'm always surprised when these reports come out. I always want to say, okay, well, ask me what I think is going to be the focus, and that's what the focus won't be. So a lot of people, when the report came out, focused on the 500,000 hours that were not delivered by the for-profit sector and the 93,000 hours more than that were funded delivered by the not-for-profit sector. I think I got that right. And those are important in the context of the total hours. Arguably, although 500,000 hours is about $20 million. But I found that the most significant part of the review, that from a policy perspective, is this concentration of the profit. So if you look at the sector overall and the profit it generates, it's not significant. I think it's, what did it say? It was about 4%. And so if you said the private sector is going to deliver all our long-term care services for us, and they're going to do it for 4% profit, many would say, well, that's actually very good value for the taxpayer. You can earn more than that on a GIC right now. The problem is that isn't what's happening out there. What's happening is this concentration of the profit in a small group of operators. 80% of the profit is concentrated in 20% of the facilities, and they're almost all for-profit. There's a couple of not-for-profits in there. Despite the fact that 74% of all facilities made a profit, 80% of that profit's in 20% of the facilities. That is telling us right there that there is a huge disconnect between the financial reports that the facilities are producing and the people who are analyzing them and making funding decisions. Part of the problem is a significant fragmentation. This group looks at this part, this group looks at this part. They don't sort of talk to each other, and what ends up happening is more money goes to there. I know that some people in the sector have talked about, well, we have to give the money back. The evidence is not there that is happening in any systemic way, because you would not be seeing this repeated profit every year. So the question is, well, exactly how did you claw the money back? And the challenge is not, somebody said money should be spent on, earmarked for care should be spent on care, not profit. It's actually even a little bit more complicated than that. It's that it can't be spent on any of the other operating costs either. So the minute you sort of start accepting the argument, well, I didn't have all my care, I couldn't deliver all my care hours, but I spent more money over here, so let me keep it. That's the slippery slope that's got us to where we are today. We've got to sort of make this decision that this is your care envelope. You spend it on care, you give it back. This is your envelope for all your other stuff. And if you need more money in that envelope, we will put it in the envelope. You can't take it from the care envelope and put it in, right? Either the rationale for funding it stands on its own merit and gets funded, or it doesn't. But this sort of allowing the money to slosh back and forth, for want of a better description, is part of what's led us into into the murky waters that we're in right now. And you can see here, this is a not-for-profit and a for-profit care home. These are real statements. And you can see the difference in total staffing costs, right? These are comparable size. They're average 151 beds. I think the not-for-profit actually has got about 4 more beds, but in any event, 4 less beds. They spent basically 13 million compared to 8 million on care. They spent 1.4 million compared to 3 million on building expenses. And you can see right here, this care home spent we paid 2.4 million for their mortgage. These guys, we only paid 300,000 for their mortgage. And then you can see the other things that we pay for. Administration was actually twice as high in the for-profit as it was in the not-for-profit. In large part because there's this huge management fee. Nobody knows what management fees are for or what the structure of who's receiving that management fee. So in the end of the day, you have this not-for-profit on its $15 million budget, losing just over $500,000. And you have this for-profit operator on its $16 million, producing a profit of 3.3 million on top of receiving 2.4 million for its mortgage and 342,000 in a management fee. And this highlights the problem, I think, most starkly. This is not the most dramatic comparison that could have been produced. It's not the totally normal experience because most care homes are not producing a $3.3 million profit, but some are producing quite a bit, and there's no connection. And you're finding that this is one of the big areas that we're seeing. So no change over 5 years, basically, is what we found, that the patterns still exist, everything still exists. We have increased funding dramatically. We've increased the care hours. We have implemented a new standardized reporting template, which, to be fair, hasn't really been actioned yet, but it's been created. We've standardized wages, not benefits, but wages, and yet we still find the same thing. The funding system is not focused on maximizing resident care, period. It is focused on this per diem and where is it, and flow through. Everybody's getting automatic increases every year, regardless of what their income statements are showing. It is interesting because I think some of the groups that represent the operators have not been supportive of the report, yet clearly the system is inequitable to operators. Clearly. There are some big winners out there, financially speaking, and some big losers, financially speaking, within the same system. And you see that repeated year after year after year after year after year. So it's not equitable to the operators either. And without fundamental reform, the issues will just continue to grow. So the recommendations, funding for care must be spent on care. The financial incentives need to ensure the operators spend the money received. In the simplest form, you would say, here's $1 million to be spent on care. If you spend all of this $1 million on care, we will give you $100,000. If you don't spend the $1 million on care, you got to give some money back, right? That's a very simplistic way of putting it, but it's got to be that prescriptive. And in the absence of that, we're going to continue to see the same things happening. Revenues and expenditures for publicly funded care homes need to be available to the public. I think people are entitled to know we report on a whole bunch of things. We should be putting their financials up there every year. We need to improve the accuracy and transparency of reporting for compliance with funded care hours. So even with these differences that we found, and even with the shortage in the for-profits and the overage in the not-for-profits, those are on what the operators themselves are reporting. Remember that all of this information comes from the forms that the operators themselves are providing to the health authority. So right now, what we're measuring is, as an operator, you're saying, I paid 100 care aides, a total of $1 million in the last year. And I don't think anybody's disputing 100 people were paid that money in the last year. But there's this other thing that can happen, and one organization does something called a multi-skilled worker, where I'm a care aide and I might do some housekeeping, or I'm a care aide and I might do some food services. I might help serve at the meal times. Those functions are not direct care. The feeding, the serving of the meals and the cleaning of the rooms, those aren't direct care. So how certain, how finely calibrated are those payroll systems to capture this is direct care, this is housekeeping? We almost need a total view of of the staffing and what needs to be spent on staffing, and then define profit. So, right now, the only definition of profit is after absolutely every expense has been counted, what amount of money is left over. And some of those expenses, most particularly the buildings. So at what point are we funding a capital asset beyond the market value? And so that is effectively a form of profit. The management fees. How do we know, is this not, or a head office allocation? Subcontracting with a company in which there's co-ownership with the operator. All of these things could potentially give people what I would call a second bite at the profit apple, but it isn't counted as profit. So we need to define it. And it needs to be then the same for everybody. And, this is what we're going to allow you to count. This is what we're not going to allow you to count. And everybody, we either allow management fees for everybody and everybody puts something in, or we don't. We've got to sort that out. So basically these 4 recommendations were made in the last report. The last report had 5 recommendations. One of them was a standardized financial reporting template for the province. That's been done. As I say, it still needs a bit to be operationalized fully, but it has started. And with that, I am going to stop my screen share and turn it over to, I think, Scott, who's going to manage the questions, or maybe Audrey. I'm not sure.
Thanks so much, Isobel. I'm going to help moderate the Q&A. So I just wanted to make a note to everyone that we did disable the chat during Isobel's presentation to minimize distraction for everyone, but it's open now. And so I'm going to kick us off with a question that that some of our members on the Seniors Care Advisory Group have brainstormed, but I'll keep an eye on the chat as well. And hopefully we have about 10 minutes for questions. So clearly we won't get to everyone's questions, but we'll do our best to select some that are a bit representative. So to start us off, one of our questions that we had planned in advance was, as we said in our introduction, we are here to kind of launch a campaign in support of funding reform, and that funding model that you said, that was the key piece. And so our question was, what can you tell us about the status of this new provincial funding model? We've heard the Minister of Health say that that's something that their government is working on. So we're curious what you can tell us about what's anything you know, what's happening, what are the next steps in your mind, and do you have any suggestions about how we can ensure that the important partners in the long-term care sector are part of the conversation in establishing that funding model?
Well, I can confirm they are working on a funding model. The work is slow. The ministry will talk about other priorities and the impact of COVID, and those are valid, but at some point, I think we've got to step away from what I call the COVID mulligan, and say, you know, we really do need to move forward with this. My concern is the lack of signaling around around specifics. Governments, they like to deal in generalities. There are a significant number, well, maybe not significant number, there are a number of care home operators who have no incentive in a new funding formula. This one is working very well for them. Others do have an interest in a new funding formula. And you cannot make all these people happy. I think, you know, I've referenced this before publicly. You can't fix this without some serious financial impact on some of these operators. And they are not going to want to have that happen.
Yeah, totally. Thanks for that answer. We'll keep digging as well about how we can make help make it move forward. I see a theme in some chats and questions and comments in the chat around the administrative costs for the profit, and how do we understand better what that category is. There's a question about whether food and medication costs, sorry, that wouldn't be under admin, but basically, I guess, can you tell us more about the buckets? And I think there's a bit of interest specifically about everything that's considered admin.
Yeah, the buckets aren't perfect in part. Now, remember, we wanted to be able to compare to 5 years ago, to our report 5 years ago, and we didn't have COVID 5 years ago. So this bucket was much smaller because it didn't have this, you know, all our masks and gowns and hand sanitizer. And it was sort of to gather it up and how we report. So it's imperfect. I would say that your supplies, right, are included, and food costs are included in that. The labor for the food is not, right? So I think it's about 70% of the overall costs. I think that's overall. I don't think that's enough. Are going basically to pay people, right? Whether it's direct care, whether it's making food, cleaning the rooms, that kind of thing. And then the other portion is going to the building, the maintenance of the building, and the supplies. Food is part of that, but in long-term care, you'll have incontinence supplies, you'll have equipment, you'll have obviously our infection control supplies now, those kinds of things.
Okay, yeah, thank you. And I think I see some people using the hands up function, and I'm just going to ask you to put your question in the chat if you have one, because we can't really manage all the hands up. I apologize about that. So in the past, when we've engaged with you, you've mentioned that over time there was a decrease in the ratio of health authority owned and operated homes, and we've seen recently a lot of announcements for health authority owned and operated homes that have been announced that will be built in the coming years. I see a question from Pegasus in the chat about Actually, about 450 new long-term care beds currently being built in interior health that are going to be privately owned and managed. And the question is, how can we insist that they at least be managed publicly, or how would this new funding model I'm going to add help address the risk that come with these privately owned and managed homes?
So the short answer is I am also a bit curious about the Interior's decision to not own and operate any of them. As you know, there's been a flurry of announcements here on the island where they're going to own and operate. And I know Vancouver Coastal, I think, has actually been buying some private care homes and are operating them as the health authority. If we fix the funding model, if you think of it this way, it's not about get the profit out of long-term care per se. This is public money. So we have a system that says if you have $20,000 a month, and there's a few care homes out there that are totally private. And interestingly enough, I don't hear any complaints about those, because when you're spending $20,000 a month in a private care home to deliver a high level of service, you're going to get what you're paying for, or you're going to take your $20,000 elsewhere, right? So it's not about the ability of a private care home to operate in the private care market. This is about public dollars. So the question that this is our money, and these are people that we have deemed responsibility for taking care of, right? And so what's reasonable for us to pay in terms of profit? If you go back to 30 years ago, when things started to shift and the private sector started to take off, the model was based on the private sector can deliver long-term care cheaper than the public can. Oh, okay, well, then we should use them. We forgot to ask, well, how can they do that? And they do it because they have either less labor, or the labor they have, they pay less for, or a combination of that. And they will nip and tuck at the margins of various supplies, right? That's where that's where you make the profit from. And we've now come to say, well, that's not acceptable. We're now paying attention. Nobody paid attention to care hours and how much, like nobody paid any attention to this 30 years ago. We're now paying attention to it. We're saying, no, wait a minute, these care hours matter. Then now we're realizing, well, wait a minute, you are going to have to pay these high wages because, on the one hand, you're saying, oh, I can't get any staff. But on the other hand, you're not paying what this facility over here is paying that's getting the staff, right? So you're going to have, so once all of that is done, where is the operator going to get their profit from? Right? So that's where governments and health authorities are going to have to think about, what is it? Is it 5%? Is it 10%? Is it 20%? And operators are going to have to think about how they're going to operate. And then people will say, the threat, be careful, or operators will walk away. Well, first of all, I wouldn't go around threatening. But secondly of all, walk away from what? It's not like you can take a care home and just decide on your own to turn it into condominiums. You need a lot of governments to approve all that. And so we do have some controls. We seem reluctant to use them in long-term care. I'm curious about that. We seem less reluctant in other areas to use our leverage points, our power points, but we do in long-term care. But there's definitely a shift coming, and I think dragging it out, hoping it'll go away, isn't going to work.
Yeah, thanks. That's really well said. I think we have time for maybe just two more questions, if we can keep it brief. So I'll try to combine for our second to last question, one from the chat and one that Lisa, who'll share in a bit, sent ahead. This question is to do with the enforcement of regulation and standards in long-term care, specifically through a responsive grievance process. I see a comment from a question from Francis and the staff around you going into a care home and seeing a difference. Like staffing and care might be different. Like there's like seeing staff just like maybe chatting around and watching TV and wondering, okay, how do we know where's the accountability? And so like I imagine a response to that might be like a family member making a grievance, like filing a grievance or complaint. And what if that doesn't work? Like, so I guess a question about how do we do a better job of accountability and what role kind of improving our grievance processes has to do with that.
Well, I think the first thing you have to recognize is it will never be perfect. The point is to keep striving for perfection, because in that process, it will continue to get better, right? And I think that I think that in our regulations, we do need to put staffing ratios. We have it in childcare when the licensing officer walks into a licensed childcare, they count up the number of staff, and it's licensed on a ratio of so many staff to so many children, right? How many children are here today? How many staff are here today? And if it doesn't meet the ratio, you get written up. We need to do that in long-term care. Right now, when the licensing inspector goes into a long-term care facility, we're taking precise measurements on the temperature of the water and on the temperature in the fridge, but we're not taking a precise measure of staffing. We're taking a general observation of whether staffing appears to be sufficient. So we need to get to that precision. You know, you're supposed to have, where's your staffing plan? There's supposed to be 4 people on this unit today. Where are they? I only see 3, right? Right. If that's what would happen if you went into childcare. So we need to get it to that point. Now that doesn't address, you've got the 4 people on the unit, but they're sitting around talking and not providing the care to the residents. You can't address that through the numbers. In licensing, you can address it through, you know, our standards of care being met, but that's a very broad term. I think the system, the healthcare system writ large, needs a better system of people being able to complain. It starts with, we don't call it complaints anymore, and we don't call it the complaint office or the complaints box. We call it the patient quality care office. And, you know, we tell us what we did right today, tell us what we did wrong, you know, that sort of thing. And all of that's important. I mean, we want to hear about the good things that happen, but really what people want is a more straightforward way of having their issues heard. Not all of their issues will be resolved. Not all of their issues can be resolved. And not all of their issues will be reasonable, right? I mean, don't forget, I've been around for 30 years. I've seen unreasonable residents and family members. I've seen unreasonable care home operators. I've seen unreasonable staff. I've seen staff who are angels. You see it all, right? And I think we need to remember that. And what I think most people want, most people are reasonable at the end of the day if they feel heard, they feel validated, and they feel that the person who's hearing their issues is really hearing their issues. And even when it can't be fixed, we acknowledge it's an issue. We don't like to do that. We don't like to acknowledge something as an issue if we can't fix it. So the language we use frustrates people because we make it seem like, there's not really an issue there. There is. And I think, but That's true not just in long-term care, that's true in hospital settings as well.
Okay, thank you so much. I think I underestimated how much was packed in that last question. So I think we're technically out of time, but if I can ask you to give a 1 or 2 sentence answer to this last question, because we did plan it in advance. We are, many of us, very sad to hear of your plan to retire, though happy for you. And so our question is, what advice do you have for us about how to best navigate the transition to the next seniors advocate and keep up advocating for the recommendations that you've already started? So how do we go on without you? And I know it's hard, but 1 or 2 sentences, because my team will be mad at me if we don't wrap up.
I think you need to continue doing what you're doing. There's an active recruitment process underway. I have every confidence that someone will be in place before I leave. I'm absolutely confident it's not a politically driven process. It's through the Public Service Agency. And I think the kind of engagement you've been doing, reaching out to the office, engaging with the new advocate, recognizing that our jobs are to advocate for seniors. Look, I focus a lot on the evidence and what, and so sometimes there's going to be agreement, sometimes there's not going to be agreement, but that to try and establish that relationship where you're going to trust that the information you're going to receive is as accurate as it can be and as unfiltered as it can be, and go forward with that. But you know, I think continuing to do the kind of outreach and engagement you're doing.
Well, thank you so much, and thanks so much for joining us today. So I'm sorry for everyone who had a question who we didn't get to. I am excited to see all of the engagement, and again, I'm sorry that we have to move on and that we've run out of time. But thanks for everyone who did think of a question. I think I hand it over to Margot.
You do, and I get to thank you, Isobel, for joining us today. And I know that we'd all like to offer and acknowledge a heartfelt thank you for your critical and evidence-driven work over the years on seniors care in light of your upcoming retirement early next year. We wish you well, but we're very sorry that you'll be moving on. We will miss your voice and our work, and we will continue to be a strong constituency to support your recommendations in the province. Next, we're going to hear some stories from coalition members about wins in the long-term care sector. Whenever we are faced with a new report like this that shows how much work needs to be done, it's important to take time to reflect on our success and progress. And there have been a lot of changes in our long-term care sector since the beginning of the pandemic. And learning about these is a reminder that we can make things better one step at a time. So on that note, I'd like to introduce Barb Netterpahl, who is the current president of the Hospital Employees Union. The Hospital Employees Union represents many of the care aides who work in long-term care. They have members in public, not-for-profit, and for-profit facilities. Barb has a keen understanding of the history of privatization in long-term care and the ways that the quality of care relies on the quality of work in the sector. We're grateful to have Barb join us to share about some of the victories that we have seen in recent years that have helped stabilize the workforce in long-term care. Welcome, Barb.
Good afternoon, and thanks so much for that introduction, Margot. And thank you so much for having me here today, especially to be able to share some of the good news that's actually happening in this sector. Again, I'm the president of the Hospital Employees Union. My pronouns are she and her. And in HEU, we represent 60,000 healthcare workers across the province. Specifically, though, about 28,000 of those who work directly in seniors' long-term care, assisted living, home support, and other settings. So we have a pretty keen idea about what the challenges are that our members face every single day. And so that's why it's been such a huge priority for us to address the state of seniors care, through like political lobbying or at the bargaining table. So I am really excited to be able to share some of the good news and the gains that we've been able to make on this front. I think, though, that we can all agree that the COVID pandemic really did shine a light on the deteriorating and devastating conditions in seniors' care. And, these are the conditions that our members have long raised warning flags about. So short staffing, high injury rates, unbearable workloads. And of course, it's the challenges of recruiting and retaining workers in this sector. And that's had a really negative impact on seniors' care and the workers that provide the care. So we've made some gains, though. So in 2018, during that round of bargaining, that would be what we call the Facilities Bargaining Association. So that's our public sector agreement, covers about 41,000 HU members. In that round of bargaining, we negotiated an additional 600,000 hours in the bargaining unit to attempt to address the understaffing by 2021. We then secured another $3 million for the education fund. And what this does is it provides funding for folks that are already in the healthcare system, so that work in the system, to upgrade their skills and so that they can move around in the system. I mean, it was a start. It barely scratched the surface, but we were happy to get some movement on that. And many members told us they were stressed out, burnt out. They were planning to leave the career that they loved. It became just too much for them. So again, we focused on the long-term care sector as a bargaining priority in 2022 when we went back to the bargaining table to try to hang on to these workers and again recruit more. So we negotiated another 9.25 million hours of staffing. So that's going to add thousands of new healthcare workers to the front lines. So more than 3 out of 4 of these positions will be regular, full-time, and in place by December 31st, 2024. So raising these staffing levels really is key to managing the workloads and creating safer work places for everyone. So we also founded a recruitment and retention working group. And that's to continue developing the plans and the recommendations for provincial health human resources. So we also then secured another $4.5 million through the education fund. We secured $300,000 to provide training in mental health first aid, anti-racism, creating a culturally safe work environments. Because addressing the recruitment and retention also requires our workers to feel safe physically, mentally, emotionally, in order for them to do their jobs. We heard Isobel talk about it, but I'm going to highlight it a little bit more. We also trained 3,000 new care aides through the Health Career Access Program, so the HCAP program. So these are HU members, who are looking to change their career. We're amongst the thousands of care aides that graduated through this program that was launched in 2020. And again, it aims to increase the number of care aides working in BC while removing the financial barriers for them to get that education. So this program, it provides on-the-job training and education in partnership with post-secondary institutions. So these folks were able to get paid to do the work. They are employer-sponsored training for a period of 12 to 16 months. And, as they worked as a healthcare support worker in the facility, so they were providing a service while learning how to become a care aide. And then on completion of the program, they are qualified, provincially recognized healthcare assistants or care aides. So this has been like a hugely successful initiative to address the staffing crisis in the seniors care sector. So it was so successful actually that in 2022, the BC budget included $25 million to support another 2,000 seats for this training. So this could be a result of like 5,000 new care aides in the system. The program was then extended and renewed again in 2023 with a commitment by health employers to provide paid work and training for 3,000 care aides in each of the years 2022, 23, 24, and 25 during the FBA collective agreement. And that's both in the public sector and community health settings. So this is really important and welcome news. And that is what unions can accomplish when we work with a labor-friendly government. So part of our Care Can't Wait Seniors campaign, HU leaders and members are currently lobbying our MLAs in key ridings right across the province to implement the BC NDP's 2020 election promise to restore standard wages, benefits, and working conditions. And that was what was dismantled by the BC Liberal government. So in addition to all of that, we also, in 2018, BC NDP government announced that they were repealing anti-labor laws that were passed by previous BC Liberal government. And that put an end to the privatization, the contracting out and contract flipping that was responsible for fragmenting the long-term care sector. Then the pandemic comes along, and the most vulnerable British Columbians are seniors, obviously in long-term care. And we heard Isobel talk about it, but in 2020, the BC NDP government passed legislation under what's called the single site order. And that order prevented staff from working at more than one facility, which, I mean, they had to do that. They had to work at 2 or 3 sites in order to make ends meet. But during the pandemic, by having them restricted to only one facility was an effort to contain the virus. And that was a really critical move to protect patients, residents, and workers as much as possible. However, what is unique to our jurisdiction is that the government also introduced that wage leveling that Isobel had talked about, which topped up the lower wage private sector workers, their wages, to match the public sector workers. So that meant an immediate jump by about 20% for some of our members. So that's significant, and it was a game changer for many of these workers, predominantly our women and racialized workers. So then through all that, we launched the Make It Public campaign, where we lobbied the BC NDP government to bring privatized workers back in-house. And they agreed that was the right thing to do. And since August 2021, more than 4,000 healthcare workers have been repatriated with increased wages, benefits, job security, and a pension plan. So that's really exciting. We're very proud of that. This work continues as we continue to bring all of the privatized jobs back into the public sector. Right now, we're working on security guards in various healthcare regions that were privatized. It took 20 years for us to reverse these contracting out, but it's happening. And we're really excited about that. And our workers were really, really united. They didn't give up. They were fighting for justice and they won. And they were really central to that campaign. The other thing was around, electing an NDP government was really important for this because, it's important for us to understand that government that can put people over profit made it a whole lot easier for us to be able to make these gains. We were able to knock on the door and walk in and have these conversations rather than yelling at, a building on the legislature lawn. So political action to our members really, really matters. The solidarity of our membership through this time was really critical for us to make these gains. And we're going to continue working on this with regards to long-term care, not just to ensure that these wages stay leveled up, but like Isobel was talking about, it's also about benefits and working conditions also need to be standardized in long-term care. So thank you so much for listening.
Thank you, Barb, for joining us today, and and thank you for advocating for healthcare workers and clients across the province. I'd like to introduce two speakers who will now share a bit about the wins in improving accountability long-term care operators by formalizing the role of family councils. Mark Tassé is the Executive Director of the Independent Long-Term Care Family Council Association of BC, and Lisa Dawson is the Chair of the Vancouver Coastal Association of Family Councils. They are part of a provincial network of family council associations that are working to build the voice of the family councils in long-term care. They too have experienced significant milestones over the past few years. So over to you, Mark and Lisa.
All right. So I'm the Executive Director of the Independent Long-Term Care Councils of British Columbia, which is a provincial association of family councils. And we're representing the collective voice of the residents, the families, and resident representatives. And we're an important partner with the Ministry of Health and a valuable resource in developing family councils and long-term care. So when we look at families and residents, they're the ones who are experiencing firsthand whether the investments, the policies, the initiatives, the programs, they're being initiated by the Minister of Health or the home care operators are actually having an impact on the quality of care. And as we saw in the report, over 5 years, a 4 to 5% increase in spending, and yet we're not seeing any significant, we're not seeing 4 to 5% increase in the quality of care or what's happening as we go through. And that's, I think, significant in the fact that the families are not being consulted and looked at. The family councils, they pool their experience and we're able to identify not only within facilities, but across the system, what are the gaps in the system and what are the solutions that need to be done to bring that ahead, whether it's food and dining experience in a specific facility that's brought to the leadership, or the regional associations that are looking at the regional variances in care and identifying the systemic issues, or if it's us at the provincial level, looking at the systemic issues identified by the family councils and bringing them through consultation, community participation, and research out to ensure that in every step of the policy, the programming, the planning that's going ahead, that the first priority and the first point that we're looking at is the needs of the residents over the needs of everyone else within the system, because they're the ones that we should be focusing on. And we saw that during COVID, right? During COVID, there was a huge impact of not having families and persons of importance consulted and when those policies were brought in. The lockouts of families and representatives took out much needed additional care that the residents had, and that led to hardship for the residents, for the families, and for the personnel. And these policies were done without any real consultation to the people most affected by the decision, the residents in care and their families. And we saw what that came out from. Part of that result, which is a good thing, is through the advocacy of the family councils and the push through that, we got changes to the Residential Care Regulation 59, which now recognizes that that not only are residents and their families to be engaged, but that they play a vital role in the efforts of providing quality care, and that resident and family councils are now required to be independent from facility or management and how they operate, and that they should be included as stakeholders in the planning process at all levels. So we now have a regulation, we now have something that says we have to start listening to the residents and the families. And this is clear, but change is always difficult because this is a paradigm shift. We have to stop just band-aiding and trying to put the masking tape on top of a bullet wound and actually change the mindset. And the mindset of some long-term care homes, ministries, and the other partners that are in this, to see that the value of working together and working with the families and the residents, it has to be the common goal and has to lead towards the residents' quality of care and improving the quality of life of these people who've contributed throughout their entire life. So there's a lot of work that still needs to be done in enhancing the quality of care and in building the resident family councils as integral parts of the care teams. But we'll eat this elephant one bite at a time. And hopefully in 25 years, when myself and some of us are going to be looking at long-term care as an option, we'll look at this as the dark ages and we'll be looking at actually quality of care. And I think I'll hand it over to Lisa.
Thanks, Mark. Families observe the activities of what goes into care, and then we experience the outcomes in our loved ones' quality of life. Family councils are the eyes and ears of our care homes. Our conversations about our observations guide our advocacy for improved long-term care. I'm a caregiver, a daughter of a resident in long-term care. I'm a patient partner in community efforts to review, assess, and recommend improvements to long-term care. I hear, see, feel, and touch the lived experience of those in long-term care with every visit with my father, who's been a resident for over 13 years. My dad's early days in long-term care were fraught with challenges navigating the system. There was no family council. Neither of us knew what we didn't know and no idea where to get the information from. There was no handbook. Communication was seemingly only one way from the care home. Only when a serious health issue came to light, or only when there was a certain staff person on duty, would I hear what was going on with my father. Communication between care home and family lacked trust and accessibility. The record played over and over. I wish there was someone to talk to. I wish there was a better way of communication. Do all families go through this? And I wish I could be part of the solution. By chance, I was introduced to the new family council that had just started. The family council had started to advocate for the collective issues of residents. And in the beginning, their issues, suggestions, and meetings with senior leadership were underscored with emotion. They were difficult to navigate. Communication was confrontational rather than respectful. And family expectations were askew. And the long-term care home had not adopted person-centered care. We were miles apart. But over time, and with efforts focused on best practices on how to run a family council, our common ground, that is the well-being of our residents, we learned to work together. We focused on successes as well as the challenges. We learned to praise openly those staff who displayed exemplary service and genuine compassion, at the same time pointing out opportunities for improvement. Now, the relationship between our family council and long-term care community thrives. We tackle issues head on together, and families are on all committees. So due to our collective observations and mechanism to bring them forward, we now have a resident and family handbook, a palliative and end of life protocol, family council page on the website with resources for families and residents, new admission process, a cookbook corner in our library, and a pop-up boutique that comes annually to sell both adaptive and loungewear clothing. We even had an opportunity to fundraise for items that sat on a wish list for over 5 years. These items weren't funded by our government, but they were brought forward by residents who identified them as being important. A few of which were an annual garden revitalization, a wheelchair washer, and 3 big smart TVs, and so much more. Family councils are helping care homes do more with what they already have. That is our voice. While family and resident councils provide oversight by way of articulating our everyday experiences and observations, we do so for the purpose of continuous quality improvement. We always try and deliver our concerns with potential solutions. We have learned to approach our asks with realistic expectations. The Provincial Association of Family Councils and its regional associations are an accomplishment amidst the failure of our government to provide long-term care with adequate human resource support, a quality of life framework to rebuild our outdated system, and a properly funded model of care to meet our residents where they are as individuals. Our Provincial Association of Family Councils supports funding for care that must be spent on care. All long-term care homes must be held to the same standards. All residents and families must have expectations around a certain level of care and quality of life that they can expect. Family councils are outcomes focused. That's all we can really measure. So the change last year in regulations which support independent family councils has been a game changer. And our mechanism of elevating our voice from each and every independent family council to the regional association and then from the regional associations through an independent provincial association of family councils who meets with our Ministry of Health regularly, is our answer and our good news story about changing the long-term care system as a whole. Thank you for our invitation.
Thank you so much, Mark and Lisa. Folks, now it's time to turn our attention to action. We need everyone here to keep building on the wins that we just heard and achieve fundamental funding reform. After hearing from Isobel, it's more clear than ever that we need funding reform before any more taxpayer dollars are turned into profit by the for-profit companies. Public funding for long-term care should be used for direct care, not turned into profit. The BC Health Coalition includes organizations that are key stakeholders in long-term care, including senior organizations, resident and family councils, workers, and their unions. We're concerned that few of them have heard much about the progress on this new funding model. Meanwhile, the association that represents private long-term care operators claims to be in deep discussions with the ministry on the topic. So we know that the for-profit companies are lobbying hard to safeguard their publicly funded profits. The government needs to hear from the public that we support their plans for funding reform. This campaign calls an opportunity to show Minister Dix and the BC government that we will back them up when they address this issue of profit in the system. So we're asking everyone on the call today to sign up and send Minister Dix a postcard showing your support for funding reform. I'm going to turn it over to Usman here to share some specific instructions on how you can do that.
Thanks, Scott. Hi, everyone. My name is Usman, and I'm the coordinator with the BC Health Coalition. First, I do want to apologize. We're going over slightly, but I promise we will wrap up within 5 minutes. So we're close to the end. Thank you for sticking around. So if you'd like to receive a postcard from us to send to Minister Dix in the mail, just go to bettercareforseniors.ca. You'll see the link up on your screen. My colleagues will also put the link in the chat as well. So on the sign up form there, please fill out your name, email, and address. And be sure to fill out the form before a deadline of November 14. So that's 2 weeks from now. So you can be sure you get a postcard in the mail. Once you've filled out the form and submitted, all you have to do is just sit back and wait for an envelope from the BC Health Coalition. In that envelope will be an instruction letter and a postcard. On that postcard, you can write your story or reason for why funding reform in long-term care is important to you. And once you've done that, just go ahead and drop the postcard in the nearest mailbox. You don't actually need postage because we'll have everything pre-stamped. Hopefully, your postcard, along with thousands of other postcards, will be delivered to Minister Dix to show him and the BC government that they have our full support to address this very critical issue of funding reform. So if you have any questions or issues with the form or would like extra postcards to hand out to your seniors group or at your community center, please contact us at info@bchealthcoalition.ca, and my colleagues will put that email in the chat as well. So be sure to go to the website link before or soon after the call to sign up. Thank you. Now over to you, Margot.
Thanks, everyone, for being here today. I think it's been incredibly informative and powerful presentations. So we'd also like to ask you to consider letting your friends and neighbors know about the possibility of sending in a postcard, as Usman described. Also, organizations will be receiving some information from BC Health Coalition as to how they can send the same request out to their members. I think that brings us to the end of our time today. I just have a few final words. Thank you to our speakers, Barb Netterpaul, Mark Passe, Lisa Dawson, and a special thank you to Seniors Advocate Isobel Mackenzie. Before I wrap up, I'd like to share a special invitation. The BC Health Coalition will be hosting an in-person town hall in Vancouver with a focus on supporting public healthcare solutions on November 20th. If you live in the Vancouver area, I encourage you to register to attend in person. We do plan on sending out details about viewing the event online. So we hope that many of you will be able to join us. If you want more information about that, go to the BC Health Coalition website, bchealthcoalition.ca, for more details on the event. And just a final thank you to all of you who joined us today. Thank you.